Good evening, everyone. We'll start our session now. The first session, Professor Dr. Gasser Bishri, Professor of Obstetrics and Gynecology in Shams University, will enlighten us about the next session titled Tips and Tricks in Total Laparoscopic Hysterectomy. اتفضل دكتور جاسر.
مساء الخير يا جماعه. انا عارف انه اخر اليوم كلكم تعبانين ف we'll go through it quickly. الفكره في او الاوبجيكتيف بتاع التوك هو strategies to maximize completion of TLH. يعني ان احنا we don't convert. دايما لما حد بيعمل اي laparoscopic surgery عنده حاجه اسمها conversion rate. ف we are trying to reduce the conversion rate, reduce complications. We're providing best surgical steps to simplify the procedure. احنا why do we do TLH؟ لأن احنا we do it because of a shorter hospital stay. The patients they can go home on the same day theoretically or next day. There is less blood loss. عشان كده in England, for example, Jehovah's Witness who cannot receive blood, they always go for laparoscopic surgery. It's with time, it's less post-operative pain, less post-operative adhesions. They go back to work quickly and they can move faster. But why do we really do it? We do it because it gives us more surgical satisfaction. We like to do it. And it's much easier. Much easier is if you imagine obese women with a very small uterus deep in the pelvis. It's a very difficult abdominal hysterectomy, and it's much easier to do it actually through TLH, through laparoscopy. When you are selecting your patients at the beginning, previous parity is an important factor with previous deliveries. In women who've had a vaginal delivery, they have a large introital space. You can morcellate a large uterus easily. The space is not tight. You can put your manipulator with a big cuff without a problem. In case of previous cesarean section, طبعا always think about bladder adhesions in general. Again, another factor is the BMI. If I have a high BMI, I have problems when I'm insufflating pneumoperitoneum. A degree of Trendelenburg, كل ما نوطي العيانة كل ما الانesthetist is not happy and he wants us because of the effect on the lungs. Difficulty in the vaginal axis. She's obese, you find the walls are actually falling onto you. Redundant bowels, omentum intra-abdominally, with excess fat intra-abdominally. What you need is a very good camera, you need a good uterine manipulator, and you need a good energy source. And as you keep on operating, you end up, your assistant could be the cameraman, and that's it. Once you are actually used to it, that's what you really need, a good energy source. Positioning of the patient, extreme Trendelenburg, this is a very helpful position. بس لازم يبقى we have to use shoulder supports. Shoulder supports are actually available with all the operating tables, and the anesthetist will always argue with you about effect on the lungs, but it has been shown that it doesn't have any effect ولا على البرين ولا على lungs. But actually putting the patient in such a position, I turn the table all the way until it stops. خلاص. Once it stops, that's the position that we can operate. It means the bowels are outside the pelvis, where you can easily operate. You don't need an assistant to keep on pushing the bowels away. Different uterine manipulator. They all have the same idea of having a vaginal cuff, where you can actually open the vagina. If the patient is a virgin, you can use a myomectomy screw as a uterine manipulator. But you're gonna lose one of your ports. For one of your ports, you put the myomectomy screw and you can push the uterus sideways as a manipulator. If she's a virgin and you do not want to disrupt her virginity. That's another manipulator, ring. I usually use when I don't have a proper manipulator, I just put ring forceps, and you can actually dissect the bladder and everything using just a couple of ring or sponge forceps, where there is no risk from burning the vagina, because the ring forceps or the sponge forceps are actually touching the vagina in a long surface area, so you never burn it. You only burn it if you touch it at a point. And when you're putting your sponge forceps, if you don't have a proper uterine manipulator, you can actually put the sponge forceps and push it all the way and open with electricity, and even if you touch the sponge forceps, nothing happens. A McCartney tube, I'm not sure whether a lot of you use it, but it has the advantage of when you are opening the cuff, you don't actually have leakage of carbon dioxide, but you will need the assistant to hold the cornea of the uterus, because it has a limited mobility of a uterus. يعني لأن هو it will be holding the cervix, and you can move it sideways. The nice thing about it is you can actually do the whole, for example, your needle holder, whatever you want. It's got a valve that does not leak air, leak carbon dioxide. And on the other hand, طبعا, if you're gonna, at the end of the procedure, remove tubes or remove ovaries or anything, you just stick it into the McCartney tube. Size of the uterus, if it's above the umbilicus, you've got to move upwards. As we always say, you can make a big uterus small by moving away. You just move away so it becomes small. Mobility of the uterus sideways, if you've got a big uterus that's filling the pelvis, it makes putting your side ports a bit more difficult, as well as presence of cervical fibroids, low fibroids, and the consistency of the uterus. If it's soft, it's easier when you are morcellating it. If you've got a large uterus, then you move your ports upwards. You can go up to 10 centimeters above the umbilicus safely. Some people prefer to put a nasogastric tube, but actually nasogastric tube is recommended if you're going to use Palmer's point. But because at the left side of the stomach, when the stomach fills, it moves sideways to the left. So if you're going to use Palmer's point, which is at the same level below the costal margin, you've got to actually put a nasogastric tube. But if you go just supraumbilical, and this is the preferred site for port entry if you've got a large ovarian cyst, large uterus, fibroids, whatever. Again, use of Zoladex, it's debatable. It will definitely reduce bleeding, increase hemoglobin while we are awaiting surgery. It shrinks the uterus, so it will make the uterus a little bit smaller. And at the other hand, it makes the fibroids a bit softer, which makes morcellation a bit easier. Now the steps, like abdominal, there's no difference. Round ligaments, IP ligaments, dissection of bladder, uterine, opening the vagina, and suturing of the vulva. And you can actually start with the IP ligaments, okay, and then do the round ligament. Doesn't make any difference, yani personal preference. That's a traditional port insertion site. You have the camera in the 10 millimeter, and you have a 3-5 millimeters. Or you can use ipsilateral ports, but make sure that your ports are at least 10 centimeters away, so you avoid the ports or the instruments hitting one another. And the assistant, again, has got 2 different points. If you're going to use an assistant, because if you have a good cameraman, then the cameraman is actually your assistant, and you don't need to put ports on the other side if you've got a ligature or something. Different securing pedicles. Bipolar, it's the cheapest way. Harmonic, the only problem about the harmonic is that it actually cuts when you are cauterizing, so it's not advisable to be used with uterine. Ligature will be the best. Some people, they just use suturing, especially in India. They take all their pedicles suturing with extracorporeal knots. So that's another way. Now, if you either start with the cutting the tubes and the ovaries, even if you're going to remove them, because if you cut here and the tube and ovaries actually fold sideways, they fold toward the side of the pelvis, then it doesn't keep on irritating you when you are operating. Because if I want to remove the tube and ovaries and then I go with the IP ligament, this tube and ovaries will be hanging through the whole procedure. So the easiest way is to dissect it from the uterus, finish the procedure, and then, as we said at the end, you're going to just hold the IP ligament, buzz and cut, and throw it in the McCartney tube or in the vagina. If you are going to start with the IP ligament, then a bit of traction will actually help. And here, starting with the round ligament. Once you've opened the round ligament, actually the carbon dioxide escapes, gets into the space, and it helps with the dissection. And here it's using bipolar diathermy and scissors and just opening the space. So you don't have to use expensive equipment. Now, one point about dissection of the bladder, one of the advantages of TLH is you don't have to dissect the bladder a lot. okay, you only need to dissect 1 centimeter of the vagina to allow you to suture. And the reason is because when we put abdominal hysterectomy, you need actually to keep on pushing the bladder because you want to push the ureter away. But here you will push the uterine away from the ureter because you put your manipulator and you push it up. So you don't need to over dissect the bladder. So you don't run into the problems of bladder denervation and voiding problems and so on after surgery, and obviously less chances of injury. Uterine vessels, securing them. Again, one important point is you've got to secure the uterine artery, the uterine vein, and you've got to secure both sides before you actually cut. And make sure that the uterus became white. And if it's not white, then go back and secure the uterine. And the reason is a lot of us, me personally, I use LigaSure that has been used I don't know how many times before. It's gonna fail maybe today or maybe next case, we don't know. So if you depend on it entirely and then you buzz and cut, you might run into bleeding from the uterine. Okay, so I tend to do both sides. Make sure that the uterus became completely white, and then you can cut it. Now, opening the vagina, this is a very simple technique with the sponge forceps, and you use your diathermy scissors with cutting, okay, and use the yellow pedal, so you're doing more cutting than coag. Because one of the problems about overcoagulation of the vagina is actually vaginal dehiscence afterwards. And this is one of the complications of doing a TLH. And as you can see, there is the sponge forceps. And don't worry, as we said, about burning. And as you introduce it, you just open it and it opens the space, and then you can carry on with the rest. So that's a very easy and cheap way if you don't have a uterine manipulator. That's the other way, using the cup, and I usually do with monopolar and then use the LigaSure bipolar to the sides because of the descending cervical, because it usually bleeds. So it's much better just to do the sides with a bipolar instrument. Now, closure of the vault, if you've got a McCartney tube, it really helps because you push it all the way 1 to 2 centimeters below the edge of the vagina, so it keeps it open and it makes suturing much easier. You can either, one of the easy ways is putting a purse string. You can actually introduce your needle from below, put all your stitches and throw the needle back, and the assistant will just take both sides vaginally and tie it. So that's a very quick and easy way. And I usually use it when I don't have a proper needle holder. Like if we are operating somewhere with no proper needle holder, then you can just use Maryland and, you know, take a purse string and throw the needle and just tie it from below. Or put a few simple sutures. Again, you can use a barred suture or a Vicryl or a Prolene as you would do in an open hysterectomy. And you can just put simple sutures, whether one figure of 8 or 2 or 3 sutures, one beside the other. Here it's a sponge or a towel actually opening the vagina because they didn't have a McCartney tube. But make sure when you're putting your sutures. And as you can see, the front bit actually, it's only 1 centimeter and the bladder is afterwards. So it's better to start from the side of the bladder to avoid sticking your needle into the bladder. So you go from the side of the bladder, okay, anterior bits of the vagina, you push with your needle the bladder and just put your suture. And you don't need to dissect a lot, as we said. Now, routine cystoscopy, few of the consultants in England actually do a routine cystoscopy after any TLH. And they inject something called indigo carmine, which is really nice. It's a red dye. And you can see the ureter spilling the red dye. So you're happy with the integrity of the bladder and you're happy with the ureters. In Egypt here, you won't always have a cystoscopy available, but you can use a hysteroscope and just have a look if you want or if you are worried. But it's for your peace of mind. Again, that's something debatable. Thank you very much.
Thank you, Dr. Gasser, for this delighting, brief session about laparoscopic hysterectomy. It seems like it's very easy when you spell it. The next session, I don't know if he's present or not, Professor Rahul Manchanda from India. I don't think he's present now, so we'll go forward to Professor Dr. Radwa Mansour, Professor of Obstetrics and Gynecology in Shams University. It will give us a brief session about the use of hysteroscopy in adolescents and women with preserved hymen.
Good evening. Thank you so much for having me today. Thank you, dear professors. I would be really quick. I'm going to talk about the use of hysteroscopy in women with intact hymen. So the physical evidence of virginity is the presence of an intact hymen. It's very well based here in our culture, based on culture, tradition, religion, belief, and social beliefs. In this part of the world, I mean in the Muslim world. Consequently, there will be always delays and implication on those women or girls presenting to us as gynecologists. So the consequence of preservation of the hymen and the religion and social beliefs will be always delayed presentation. They will suffer a long time before seeking medical advice. They will always present with possible complications, and there will always be delay in management. So the challenges when virginity matters to us as gynecologists, you will be restricted in examining such young girls or women, and not just the examination, there will always be restriction in investigations that are available for them as well. So when vaginal examination is necessary, virginity might be limiting for us as gynecologists. So hymen preservation during the investigation of suspicion of genital tract lesions allows virgins, always will get virgins to refuse invasive procedures or examination to reach a proper diagnosis. Vaginoscopic hysteroscopy is considered the gold standard technique for diagnosis and management of variety of different genital tract conditions. And the use of vaginoscopic technique in doing hysteroscopy will almost always preserve the hymen in most of the cases, and we have seen it a lot in our unit. So although this is a fact in practice, many young girls and non-married women will still refuse to do this procedure because of their fear about their virginity. So many years ago, we have started using vaginoscopic techniques even before my training in Ain Shams University in early cancer detection unit and in gynae endoscopy unit. So basically, it is the introduction of the hysteroscopy without grasping the cervix or putting a vaginal speculum. And it has been there now for more than 30 years, as I said. So we usually will have these women presenting to us with different presentations related to our specialty. Basically, we have abnormal vaginal bleeding, amenorrhea. Some women or young girls might be presented with abnormal vaginal discharge, pelvic pain, or pelvic masses. So, as I said, there will be always restriction with the examination of them. So we'll see our protocol and how what we offer them for examination. And there are always restrictions as well with the modalities of investigations that we might use, basically our gold standard transvaginal scan. So we might opt for something else, for example, abdominal ultrasound scans, transrectal ultrasound scans, and they have discussed in the previous session about they might use the transrectal scans as well for ovum pickup in fertility preservation for women who need fertility preservation procedures. MRIs are considered gold standard technique for the diagnosis of different Mullerian Mullerian abnormalities, and we might offer them examination under anesthesia and vaginoscopic hysteroscopy. Patient satisfaction is an issue, and acceptance of different modalities is another issue. So if you're going to offer them transrectal scan, their acceptance and satisfaction might be a bit not fulfilled. MRIs are usually acceptable, but still an expensive investigation to be offered. Examination under anesthesia and vaginoscopic hysteroscopy might be the way, after good counseling, that they will maintain their virginity. So different lesions that we might encounter in those patients. We have seen versions like at the age of 50 and postmenopausal, and they are still worried about vaginal examination and transvaginal scans. So you might find different types of pathologies like endometrial hyperplasia, and we've been treating women in their 20s and 30s with medical treatment for early endometrial cancer. Polyps, fibroids, and endometrial hyperplasia are lesions that might be present. The other aspect is seeing different Mullerian agenesis and different Mullerian tract abnormalities, and I will present a case later on about the transverse vaginal septums. They are always presented in the adolescence age, especially in the obstructed Mullerian agenesis problems, and the gold standard techniques for the diagnosis are basically MRI, and then we can offer to fulfill the diagnosis and introduce management by hysteroscopy. So we know that young girls might come with offensive vaginal discharge, and we might find different foreign bodies. We suspect foreign bodies. We have removed many fascinating and weird things. I will. This one thing I have removed from a girl that has been there. It has been in her for more than 2 years. It's a glass lens that she has put in herself for 2 years. She forgot about her, and this is what I have taken out after a vaginoscopy in a 14-year-old girl. We're proud that we have looked at the use of vaginoscopy in versions, and we have a publication that came from our unit. They have included 41 patients. Their age range was 10 to 50 years, and they were all virgin, and their presentation was pain, amenorrhea, and discharge, and this is the publication. So normal findings by a hysteroscopy was in 9.7%, nearly 10% of them we found nothing. In 15% we found thick endometrium, and we find different lesions that we have looked at, like endometrial polyps, cervical polyps, obstructed hemivagina, and ipsilateral radial anomaly, overa, and we'll talk about this case. Submucous myomas, malignancies, which is nearly 7% in those cases. Vaginal cyst, distal vaginal atresia as well, in around 10%, and non-communicating cornea with hematometra in 2% of them. So the problems with doing a vaginoscopic hysteroscopy, if we compare it with other modalities for diagnosis, is it is still an invasive procedure. We opt to do it under general anesthesia for virgin women because they will be very anxious about doing it if they are not, if they are awake. the benefits are you use it for confirmation of the diagnosis and planning for management, if not offering management and treatment. So ovarian syndrome, one of the cases that we have encountered in those patients, it's simply, as it's shown in the diagram, obstructive hemivagina with a transverse vaginal septum with ipsilateral same side renal agenesis. So the case was a 12-year-old girl presented with continuous abdominal pain for 3 months, duration which was progressive and not responding to usual analgesia. She had the menarche of 2 years ago, and usually obstructive lesions needs few years to be presented after menarche because it takes a while for blood to accumulate and cause a mess. So she was misdiagnosed many times as irritable bowel case, and she had received treatment for this without any improvement. Then she was referred for an ultrasound which suspected the presence of a mass or hematometra. Physical examination, you will look at her external genitalia, you find a normal hymen with a vaginal opening, and her abdominal examination was unremarkable. She had a 3D ultrasound which showed bicornate uterus and marked hematoculpus, a picture suggestive of imperforate hymen, and this is what you can find. You would see with different investigations that you might have different diagnosis, and then you would confirm it with a hysteroscopy. So the MRI as well suggested that this is a case of imperforate hymen. And if you're ready with the imperforate hymen and with the physical examination, you can find this. And then you go with a hysteroscopy, you will find that the obstruction is actually quite higher up in the vagina. So you need the hysteroscopy for the diagnosis and, of course, for the release of the obstruction and management. So vaginoscopy under general anesthesia found a normal side of the uterus, hemi-uterus, with a normal draining side, and the other side was obstructed by a transverse vaginal septum. You cut it out and you drain, and then her problem was relieved. So the tricks is using this technique in versions. And actually in any other cases, or especially with Mullerian agenesis problems, is the proper assessment. You need to properly assess the patient so as to plan for her further management, especially if this patient had previous surgeries, which will implicate on your success rate on the decided procedure you're going to do. So the always surgeon will have the better result as always. The planes are clean and there is no fibrosis, and the risk of morbidities like urinary tract injuries and so on will be the least in the first procedure. Imaging, proper investigations and assessment is key to plan for the management. First procedure carries the best chances for success, that's always, and you have to decide whether your patient will need any follow-up and how you're going to follow her up. I would like to thank all my professors. I have learned this in Ain Shams University. I'm affiliated to Ain Shams University, Obstetric and Gynecology Department. And I would like to thank all the staff members, nurses, and everybody in early cancer detection and gyne endoscopy unit whom I owe my training. Thank you.
Thank you very much, Dr. Radwa. Can I invite our last speaker, Dr. Rahab Abdurrahman? She is a professor of Obs and Gynae in Shams University and the general manager of the hospital. She will be talking about robotic surgery in gynecology.
Thank you, Chairman Persons, Dr. Gesser and Dr. Sweet. My presentation will be very quickly because at the end of the day and before lunch, هو يعني is there anyone here speak English؟ نتكلم بالعربي يعني. ده just introduction to report يعني. أو ما فيش حد another nationality. Okay. robotic surgery in gynecology. انا هتكلم بسرعه جدا طبعا عشان الوقت. احنا تجربه الروبوت دي حصلت في مصر قبل كده في معهد الاورام، وكان اللي موجود جهاز الدافنشي، وللاسف لاسباب لوجستيه الموضوع ما خدش وضعه يعني. ظهر تاني عن طريق السي ام ار. الجهاز موجود في مستشفى عين شمس التخصصي، هو عباره عن versus surgical system. It's a robotic system used to perform minimal access surgery. The versus surgical system comprises surgeon console, visualization bedside unit, an arm mounted on a cart, an endoscopic camera, one or more instrument bedside unit, and surgical instruments around 6 with associated cables and wraps. Versus bedside unit are draped and used next to the operating table within the sterile field, and the surgeon console is used in the same operating theater outside the field. طب احنا بنستخدم الروبوتك سيرجري ده في ايه؟ هم عملوه في حاجات كتير قوي. سي ام ار، في الهيستراكتومي، في الكوليسيستكتومي، في الراديكال نفراكتومي، في البروستاتكتومي، في الانجوينال اند فنترال هيرنيا اون هيومن كاديفرز. لكن بمنتهى الامانه هو الفايده الحقيقيه في موضوع الروبوت هو فور بروستاتكتومي. ده يعني الفايده الحقيقيه يعني. بيكون من ايه؟ ده الكونسول. الكونسول ده عباره عن حاجه كده زي قاعدين عليها زي شاشه كمبيوتر، وبنشتغل كاننا بنشتغل على بلاي ستيشن. ده الهاند كنترولرز اللي احنا بندوس عليها الباتونز اللي فيها. وبعدين مطرح الكاميرا اللي هو حد واقف بالمنظار في فيجواليزيشن يونت. ده المنظر بتاعها. في الاخر بتاعها بعد ما بنعمل درابنج للفيجواليزيشن يونت بتتركب الكاميرا وبتاخد البوزيشن بتاعها مطرح الكاميرا مان في الاندوسكوب، في اللابروسكوب سوري. طيب البيت سايد يونت ده المنظر ده بعد الدرابنج. ممكن نحط 2 3 4 وبنعمل لها الدرابنج. ليه الدرابنج؟ لان ده ما بيتعقمش، يعني البيت سايد يونت ما بتتعقمش، فالدرابنج ده حاجه ستيرايل بتركب ديسبوزبل وتتشال تترمي. متوصلين ازاي بالكونسول؟ دي الطرق، يا اما سبايدر يعني في كيبل خارج من الكونسول للفيجواليزيشن بيت سايد يونت والاذر بيت سايد يونتس، او دايس تشين يعني خارج للفيجواليزيشن ومكمل لبقيه البيت سايد يونت، او هايبريد يعني الاثنين، يعني كيبل خارج من الكونسول رايح للفيجواليزيشن بيت سايد، وكيبل اخر خارج لبقيه البيت سايد يونتس. طب يعني هي ايه القصه ببساطه؟ القصه ببساطه ان بدل ما في بني ادمين جراح ومساعدين هم اللي واقفين جنب ترابيزه العمليات، هم اكشوالي احنا بنركب الحاجات دي وبنوقف البيت سايد يونتس جنبها، والجراح بيخرج خالص بره الفيلد الاسترايل ويقعد على الكونسول يدي اوامر عن طريق الكيبلز الكونكتد بين الكونسول وبين البيت سايد يونت. هل الموضوع مفيد؟ هو مفيد. ليه؟ لان الفيلد اكيوريت 3 دي، الشاشه شايف الحاجه، اليوريتر البلاد فيزل، الارجونومكس احسن طبعا، لور ريت اوف انفكشن لان مفيش تدخلنا احنا الفلامينال فلو، فيجواليزيشن افضل بكتير، more comfort for the surgeon. طب هل ده معناه ان هو حاجه هايله وممتازه؟ لا طبعا، لاسباب عديده. السبب الاولاني ان هو بياخد تايم كبير جدا فور بريباريشن، لان انت لو علشان تقدر المسافه اللي هتحط فيها الفيجواليزيشن بيت سايد يونت او الاذر بيت سايد يونتس، لو بني ادم عادي واقف، لو الجراح او المساعدين هيحرك ايده وهيحرك البوزيشن بتاعه، لكن المشكله ان ده مكان ما هتحطه مش هيتحرك خلاص، فانت لازم تبقى حاسب من الاساس هيتحرك ازاي جوه بطن العيان. المشكله الثانيه ريستريكتد يوزج اوف الكتريستي. هم حتى الان سي ام ار حاطين يا اما المونوبولر يا اما الباي بولر، لا اقدر استخدم ليجاشور ولا اقدر استخدم هارمونيك ولا اي نوع اخر من الالكتريستي. الدرابنج بياخد وقت، وزي ما اتفقنا البوزيشننج it takes time. الاول عملنا تريننج على الكونسول الاول which was difficult الحقيقه، اخد وقت طويل جدا التريننج، وبعدين بدانا نشتغل على هارد لاب، يعني ده كده الوضع واحنا قاعدين على الكونسول بندي اوردرز للايه للبيت سايد يونتس. ده بقى واحنا بنعمل البوزيشننج، ودي اصعب مرحله لان لازم نحطها ونبقى متاكدين ان هو هيتحرك في الانجلز دي، لان لو خبطوا في بعض هيحصل الارم الاوبريشن بتقف، وده بياخد وقت طويل قوي انك تعيد البوزيشننج تاني وتتعقم من جديد وتقف تاني. again ده الهارد لاب. بعد كده بقى عملنا على كاديفر على ويت لاب. على فكره التريننج اللي كان بيعملنا تريننج دول نيرسز، يعني ولد منهم كان نيرس وولد منهم كان مهندس اجهزه طبيه، مش دكتورز. الاماكن زي نفس الفكره، البورتس اللي بتدخل عادي جدا في اللابروسكوب، يعني بنفتح فتحه البورت وندخل عادي جدا. طيب الجهاز جه في عين شمس التخصصي. الجهاز المفروض ان هو بيخدم الثلاث تخصصات، الجراحه والنساء والمسالك البوليه، اليورولوجي يعني. لكن بمنتهى الامانه هو طبعا اللي واخد البيك في الشغل هو اليورولوجي عشان البروستاتكتومي. وقبل ما يبقى عندنا روبوت ان ايجيبت، كانت الناس اللي بتحب تعمل راديكال بروستاتكتومي كانت بتسافر دبي وبتسافر انجلترا علشان تعمله. دي كانت اول حاله حاولنا نشتغلها انا وزميلي الدكتور محمد عبد الفتاح، خدنا تريننج سوا، وكانت اوفاريان سيست، واحنا كنا قلقانين جدا، وكنا حاطين جنبنا ان احنا تو تشينج تو يعني ان احنا نعمل لابروسكوبيك اني تايم. بدأنا نشتغل في الأول، هو اللي كان قاعد على الكونسول وأنا كنت بساعده. طبعا هو مش المفروض إن يحصل كده، المفروض إن هو يشتغل تماما وما يبقاش حد مننا جوه الفيلد، بس إحنا كنا قلقانين في أول حالة. ده الفكرة بتاعت البوزيشننج بقى، لازم نحط على المسافة اللي يقدر يتحرك بيها البيت سايد يونت بالجوينتس بتاعته من غير ما يخبطوا في بعض. بعد كده بنقف التعقيم وبنقعد على الكونسول. حركه الالتين بتتم عن طريق الالوان اللي موجوده في البيت سايد يونت، يعني في بيت سايد يونت لونها اورانج ومحطوط عليها السيزر، وبيت سايد يونت لونها بيربل ومحطوط عليها البايبول. ده المنظر. المفروض ان احنا خلاص خرجنا بره الفيلد وحد قاعد بيشتغل، وهوري حضراتكم بقى الفيلد الناحيه الثانيه شغال ازاي. هو بيتحرك وانت بتديله الاوردرز وانت قاعد من بره، واللي قاعده في النص دي النيرس عشان ماسكه المانيبيوليتور، دي كانت تي ال اتش. اخر حاجه بنصور الباركود علشان يعد الحالات. فاينلي لازم يبقى فيه لايسنس للتعامل مع الجهاز. ثانك يو.
Thank you very much, Doctor. Can I ask you one thing? يعني انت you mentioned الانفكشن اقل، بس احنا اللي هنحط البورتس بايدينا وبعدين هنوصلهم بالارمز ونطلع نقعد. طب ليه الانفكشن اقل من لابروسكوبي؟ ولا انت comparing it بلابروتومي؟
لا انا مش بكمبير باللابروتومي، بس هي كل اجهزه السي ام ار موجوده ان كبسولز، والكبسولز كلها فيها لامينار فلو.
يبقى عشان اوكي،
هو
عشان
ده الفكرة
اوكي
يعني. هو ما بيتحطش في غرف عمليات عاديه،
اوكي.
هو بيتحط في كبسولز مودولار سيستم.
في نقطة في انت قلتي البوينتس اوف ويكنس بس نسيتي اهم بوينت،
اللي هي
البرايس.
اه
البرايس كام؟
بص حضرتك، هو الجهاز لما جه، وقت ما جه، لما كان
لا يعني قصدي
وقتها
انا جايب عيانه دلوقتي عايز اعمل لها تي ال اتش في اي حته، how much will she pay للتخصصي؟
بص، هو اللي حضرتك قلته طبعا هو عامل ليميتيشن للقصه، وده اللي مخلي دلوقتي كمان يعني بيهدد الجهاز بانه يتوقف. علشان نبقى متفقين يعني، لانه هو وقت ما جه الجهاز نفسه ب 40 مليون جنيه.
تمام.
الالات المفروض انها ديسبوزبل، طبعا احنا في مصر ما بنعملش كده، احنا يعني
طبعا
طبعا يعني. فهو الست الات دول المفروض ان هم بيستخدموا ويترب، ده المفروض. اكشوالي هو لو احنا قلنا عيانه لابروسكوبي عاديه، ده بياخد اكسترا عليه $1000.
اوكي.
فهو رقم بالنسبه لنا مهول.
$1000 فوق
فوق
يعني لو هي هتدفع مثلا 40 50 الف هنحط عليها
كده.
حوالي كمان 50 الف.
بالظبط كده.
اوكي.
فهو طبعا ده في حد ذاته من الحاجات اللي عامله لها ليميتيشن، لان هو كان جاي بفند معين يعني ات تايم، والفند خلص، فده من الحاجات اللي عامله لها ليميتيشن، وممكن يهدد الموضوع ان هو ما يكملش. بس هو يعني زي اي حاجه بتبدا في الاول بيبقى صعبه وفلوسها، وبعد كده الاجيال بتتعلمها والدنيا بتاخد وقتها يعني.
بالظبط.
بيتهيألي القصة دي ممكن لو بقى في نظام تأمين صحي عام كدولة يعني، فبقى في سيستم لده حاول سبورت القصة. لكن طول ما هو القصة معتمدة شوية على ان البيشنت هو اللي بيبي، هتعمل شويه ليميتيشن للكلام ده، او على الاقل هتبقى ليميتد لسيرتن كاتيجوري في المجتمع.
كلام حضرتك مظبوط يا دكتور محمد. دكتور محمد سويد بيتكلم صح طبعا، وهو الحقيقه الكلام ده نوقش وبدا يتم بس على مستوى البروستاتكتومي فقط. لم يعني ما دخلش لا في الجراحه ولا في النساء، في الفيلد بتاع الجراحه او النساء. هو تم فعلا وبيتاخد عليه موافقات للبروستاتكتومي يعني دلوقتي. يعني فعلا كلام حضرتك مظبوط، لان هو فعلا هي لازم جهه هي اللي تتحمله يعني.
طب نشكر دكتور حابب طبعا على البرزنتيشن، وكنا لو في حد في الاودينس، احنا كنا الاسئله كلها متاجله للاخر بالنسبه لاي سيشن من الثلاثه. لو في احد من الاودينس يحب يسال اسئله هيز مور ذان ويلكم. Thank you everyone, و hoping to have a nice dinner بقى.